Hello class. I'm just going to finish up the cardiovascular system and talk a little bit about hypertension, some of the infections, valvular diseases, primarily the aortic and mitral valves, and then finish it up with peripheral vascular disease. The first one I'm going to talk about, as you can see from the PowerPoint, is hypertension. And this definitely is a problem with cardiovascular disease, and the concern we have for patients with hypertension is that some patients or people don't even know that they have it. It can ultimately lead to serious chronic diseases. It's sometimes referred to as the silent killer. And the important thing is that when we are assessing blood pressure, that we are sure that our blood pressures are accurate. And to ensure that accuracy, we want to always make sure that we are using the proper size blood pressure cuff, because cuffs that are too small, blood pressure can be too high, and with cuffs that are too big, blood pressures can be too low, and it really doesn't give us an accurate reading. And much of the non-surgical treatment for or medical management of blood pressure, of high blood pressure, is pharmacological management. Okay, so these are some of the objectives when we talk about blood pressure, because we really do want to teach our patients about a plan of care, and maybe even suggesting changes in lifestyle modifications for a person who does have hypertension, and really making sure that our patients do understand their medications and that they are pretty compliant with them, so that that blood pressure can be properly managed without some really serious effects of it later on. Defined by the 7th report of the Joint National Commission on the Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, it is defined as systolic pressure greater than 140 millimeters of mercury and a diastolic pressure greater than 90 millimeters of mercury, based on the average of 2 or more accurate blood pressure measurements taken during 2 or more contacts with a healthcare provider. So that's kind of the baseline where this particular commission stated as to what hypertension is. But we're going to further look at that, because those parameters have been changed to really hopefully ensure that our patients or our communities have really even lower blood pressures, because they're finding out with a lot of research that really that normal blood pressure is a systolic of 120 or less and a diastolic blood pressure of 80 or less. And as you can see from this chart on the PowerPoint, you can see that depending on what your blood pressure is, there are certain blood pressures that kind of dictate if you are pre-hypertensive or if you're stage 1 or stage 2. And I'll let you look at those. No need for me to read those to you. There's a lot of things that unfortunately influence the development of hypertension. Increased sympathetic nervous system activity, increased reabsorption of sodium, chloride, and water by the kidneys. We've talked about the renin-angiotensin-aldosterone system, decreased vasodilatation, and of course our type 2 diabetics who become insulin resistant. As you can see from this chart, there's a lot of factors in control of blood pressure. Obviously, dietary, including excess sodium intake, fewer nephrons, where we're starting to have some renal insufficiency. Stress plays a fairly important part of it. Some of the genetics that we have, obesity, and some of the endothelial factors. And as you can see, the arrow points down to many other things that cause our patients or ourselves to develop hypertension. And when we talk about hypertension, really there's no symptoms other than these numbers that we see elevated with the blood pressure. When we start to see symptoms of hypertension, where we can definitely assess organ damage, these are some of the things we might see: retina and other eye changes, renal damage, myocardial infarction, cardiac hypertrophy, and of course our patients can develop stroke or cardiovascular accidents. These are all the risk factors which really make sense, because these are some of the ones we've been talking about all along when it comes to patients acquiring cardiovascular disease or coronary disease. These are the different types of hypertension, or the etiology of why patients do develop hypertension. Primary or essential or idiopathic hypertension is probably one of the most frequent types or etiologies of why a person acquires hypertension. It's elevated BP without an identifiable cause, and this accounts for about 90 to 95% of all the cases of patients who become hypertensive. Okay, and these may be, some of the, contributing factors where we definitely see, sympathetic nervous activity stimulation, some of the sodium retaining hormones and vasoconstrictors, patients who develop diabetes, where your BMIs are exceedingly above normal range, increased sodium intake, and of course excess alcohol intake. Another type of hypertension where the etiology is from a different cause is secondary hypertension, where you have elevated BP with a specific cause, and this is in about 5 to 10% of all adult cases. And what we mean, by that is where we see, patients that might have a tumor in their adrenals, which we call pheochromocytomas, maybe patients that develop Cushing's disease, maybe a person has renal artery stenosis, maybe a patient develops renal disease. So these are some of the reasons that a patient may develop secondary hypertension. Okay, and I'm not going to go into these in detail, but you can see that history and assessment are very important when we're trying to determine the etiology of why someone develops hypertension, and then obviously beginning to manage that hypertension to hopefully prevent some of these potential symptoms that happen with certain target organs, angina, shortness of breath, things like that. And as I said before, it's very important that we, before making that diagnosis of hypertension, that we make sure we're using appropriately sized cuffs to ensure accurate readings. Patients should be seated quietly for 5 minutes in a chair with their feet on the floor and their arms supported at heart level. And then we should obtain at least 2 measurements. And remember that our blood pressures are typically highest in the morning and lowest at night. And this is just a question to think about. Tell whether the following statement is true or false. Normally blood pressure should vary by no more than 10 millimeters of mercury between arms. I'm not going to give you the answer. I will let you figure that one out. And these are just signs and symptoms of hypertension: blurred vision, fatigue, headaches, nosebleeds, nocturia. Believe it or not, the incidence of hypertension is quite high. 1 in 3 people will have increased blood pressure, and more men than women until the age of 45 have hypertension. and then later on, after 50s, women seem to develop higher blood pressures than men. We also look at that population of African Americans because we know that those particular group of people who develop chronic renal disease, many of them are from that African American culture who have had uncontrolled hypertension, and that is what definitely has caused their renal failure. A lot of people do have hypertension, and some of these people have absolutely no symptoms. But then, as I said before, many of them can have, 1, 2, or 3 of these symptoms. That's why when we talked about some of the problems with the upper airways, we really always want to look at nosebleeds, because sometimes it is just from irritation or dry mucosa, but a lot of times it is a red flag or a warning sign that someone may be developing or has already hypertension. And really there's no one test that can actually diagnose that you have hypertension, but we look at a series of labs just to kind of get an idea if someone has hypertension which has caused some kind of organ damage. Obviously, urinalysis, creatinine clearance, looking at patients' electrolytes and glucose to determine if they might be a diabetic or even a pre-diabetic, BUN and serum creatinine levels, looking at serum lipid profiles, our patient's ECG, or even an echocardiogram to kind of look at the whole general function of the cardiac muscle. And this is just, diagram of some of the organs in which many of the prescribed medications for the management of hypertension, where they actually work, the sites of action of some of the antihypertensive drugs. And beta blockers, ACEs, are ARBs, and some of the aldosterone receptors. And I'm not going to read all those, but you can kind of look at exactly where these medications work to manage someone's high blood pressure. Again, like we've talked with any medication, sometimes the first medication that physicians will prescribe for someone who has finally been diagnosed with hypertension might be a diuretic. Sometimes it might be a mild one, like I said earlier in one of the previous classes, is a mild diuretic like hydrochlorothiazide, or even a beta blocker. They'll try them on that and see how the patient does for a few weeks. Obviously starting them at a very low dose just to see how the patient responds to the medication. And we can always increase that or add a second medication if the blood pressure isn't being well controlled. And sometimes our patients are very hard to control their blood pressure, and so at times multiple medications may be needed to control blood pressure, along with looking at someone's lifestyle changes to help with the medications to control blood pressure. Okay, and we want it to be a blood pressure that the patients are able to tolerate well, where they feel good, no signs and symptoms of being dizzy, no development of orthostatic hypotension, making sure that that particular pressure that we see occur from the medications is perfusing properly to the brain, to the heart, and to the kidneys, that all systems are functioning properly. Here's a list of some of the medications, and these are very much a repetition of what we've already discussed for our patients in the treatment of heart failure and even for angina. Your diuretics and related drugs, your thiazide diuretics, they, again, as with the loop diuretics, increase potassium secretion. Maybe if those are not working very well, the physician may prescribe a loop diuretic. Sometimes a potassium-sparing medication like aldactone may be ordered, and in that case it's necessary that we watch for hyperkalemia. Some of your aldosterone receptor blockers, beta blockers, because another action of beta blockers is to block the release of renin, and when that happens, obviously the continuation of the renin-angiotensin system is not carried out. Many times too, we may see patients put on some of these central alpha-2 agonist and other centrally acting drugs, and an example of this would be clonidine or catapres. And how this particular drug works is it decreases peripheral vascular resistance. Another group of drugs used for hypertension is alpha adrenergic antagonists, and examples of these is prazosin or minipris, or doxazosin, Cardura, and terazosin or Hytrin. These also cause vasodilatation, where you have to watch your patients for the possibility of developing postural hypotension. So those are just some other ones that may be ordered. Again, vasodilators such as calcium channel blockers. We know about ACE inhibitors. Watch for potential problems with angioedema, some of your angiotensin II antagonists, and as I said before, calcium channel blockers. An example of one of those aldosterone receptor antagonists is Inspar, and it definitely excretes, again, sodium and water. Okay, and these are some of your renin inhibitors. Tecturna vasodilates, decreases blood pressure, and decreases peripheral resistance, and hopefully increases cardiac output. And these are the ones we already talked about. Alpha adrenergic dilates arterioles and veins, decreases blood pressure. It can also be used for BPH, which is benign prostatic hypertrophy. And again, this is just a slide talking about lifestyle modifications for blood pressure reduction. And one good thing to do is to try to lose weight. Sometimes that's all it takes to help bring some of that blood pressure down. Sometimes with 10 kilograms loss, which is a little over 20 pounds, it can actually reduce systolic blood pressure from 5 to 20 millimeters of mercury. DASH eating plan is a good way to kind of change your dietary habits. It adopts a diet rich in fruits, vegetables, and low-fat milk products with reduced saturated fats intake. Okay, and of course we've talked about sodium restriction, increasing physical activity, and obviously moderate alcohol consumption. And just a little more information. DASH is an acronym for Dietary Approach to Stop Hypertension. Okay, and obviously the big one is to definitely quit smoking. And as you can see by the asterisk here, according to the DRI recommendations, sodium intake should be limited to 2,300 milligrams daily. And in order for people to be able to kind of come close to that, we should encourage people to begin reading the labels of the foods they eat. Some people would be absolutely surprised about how much sodium they take in a daily amount of time. Okay. And these are some of the goals we set for our patients. Hopefully they will understand their disease process, because I think people don't really know the unfortunate effects of unmanaged hypertension, what can occur, especially when we talk about eyes and the heart and the kidneys and the potential for stroke. So we want our patients to be kind of involved in their care and to really understand their treatment. It really is all about patient-centered care. And really getting our patients involved and really considering their cultural beliefs and individual attitudes when formulating treatment goals. Because obviously with many of these cultures, food and dietary habits play a big role in their daily living. So you want to be very respectful of that, but maybe little adjustments can be made that could definitely help manage their blood pressure. What our concern is, sometimes we see patients develop extremely high blood pressures, and we call these hypertensive crises or hypertensive emergencies. And this is when we see blood pressures which, you know, exceed 180 systolic and even diastolic and go above 120. Our goal is to get that blood pressure down as quickly as possible to prevent damage to target organs. We really want to get that blood pressure reduced 25% in the first hour, and then gradually reduce it to a normal range over a period of days. The exceptions of that are somebody that has ischemic stroke and a aortic dissection, and that makes sense because we don't want to lower it too much, because it can cause possible death for our patients. Our patients may come in with some very serious side effects, or not side effects, but manifestations or symptoms with hypertensive crisis: severe headache, blurred vision, dizziness, even somewhat disoriented. Our goal is to give IV vasodilators. One common one that we give in the emergency room, IV a titrated medication, sodium nitroprusside, narcardipine, and these other medications to just help relax the arterioles and get that blood pressure down. These patients might even have an arterial line put in, so we can monitor their blood pressures, every 5 minutes to make adjustments with these medications. Our concern is the possibility of them having a stroke. So at the same time we're trying to bring down their blood pressure, we're also assessing their neural status, checking their pupils, making sure they're moving all their extremities. And we also want to assess their cardiac function, watching that blood pressure, watching that heart rate, and, watching their EKG pattern to make sure that they're not developing any serious arrhythmias or complications from that. So that's hypertensive crisis. After the immediate crisis is dealt with and their pressure is starting to come down, these patients will be admitted to the critical care unit and watched for at least 24 to 48 hours and determine, was there a precipitating factor that caused them to develop this hypertensive emergency or crisis, and then what are we going to do to prevent this from happening again, and really beginning to discuss some serious medical management of this person's hypertension. So those are pretty much the main concepts from hypertension. We've talked a lot about the medications in other disease processes, but again, remember with hypertension, thiazide diuretics, and that's for patients that might have a somewhat uncomplicated hypertension, because you can use it as a single agent, or it can be in combination with other classes of drugs. Okay, The one thing with some of your thiazide diuretics are they can, the person can experience decreased libido and decreased sexual performance. So that is a really major concern for some of our patients, and we'd hope that what it really was very bothersome to them, that they would discuss it with their physician. We've talked about loops, potassium-sparing diuretics. One thing with your thiazide diuretics, use caution with some of your patients who might have gout or hypernatremia. Maybe with some of these patients who are at a risk for developing hypokalemia, might want to talk to them about foods high in potassium. Talked about calcium channel blockers, ACE inhibitors, ARBs. One thing I read about ARBs, an example of one of those is losartan or Cozar. They're not as effective with African Americans unless these drugs are taken with diuretics or beta blockers or even calcium channel blockers. So I thought that was quite interesting. We've talked about the aldosterone receptor antagonist. Blocks the hypertensive effect of some of the mineralocorticoid hormone such as aldosterone, and as I said before, Inspra is an example of one of those. Beta blockers again, renin inhibitors, Tecturna, and again those central alpha agonist and your alpha adrenergic agonist. So that's pretty much some of the important information from your section on hypertension. Okay, now I'm going to talk about mitral and aortic diseases, and then talk briefly about some of the cardiac infections and cardiomyopathies. Okay, so let's just proceed with this PowerPoint. Obviously, this is just the basic anatomy of the heart. The heart has two atrial ventricular valves, the mitral and tricuspid, and two semilunar valves, the aortic and the pulmonic. And the two type of problems that we see with the valves in the heart are stenosis and regurgitation. Okay. And what do we mean by stenosis? It's when the valve orifice is restricted. Just think about it. Sometimes calcifications is an example of the problem that's occurring, and that lumen or opening now is narrowed, just like what happens in the coronary arteries where atherosclerosis occurs. So the lumen or the coronary artery is stenosed. And that's exactly what's happening in this orifice of this particular valve. So what then is going to happen is the blood that will be emerged from that orifice, that forward blood flow will be impeded. And so what happens is a pressure gradient is created across that valve. And the pressure gradient differences reflects the degree of how serious that stenosis is. And we can find out that information in the cath lab, because when we take our patients down to visualize the coronaries, that's a left-sided heart cath. But then to check these pressure gradients across the valves, that's what we call a right-sided heart cath, and it takes a lot longer. And that's where we can get the information about the differences in those pressure gradients. Okay, so the first thing we're going to talk about is mitral valve stenosis, and think about what side of the heart this valve is at. It's obviously on the left side of the heart. Usually, mild stenosis is usually asymptomatic, but as that orifice begins to continue to narrow, you have pressure in the lungs increasing, and the patients will have dyspnea and exertion along with orthopnea, PND, palpitations, and dry cough. The majority of people who develop mitral valve stenosis are from the adult cases that result from rheumatic heart disease, okay? And what happens is it's just a thickening by fibrosis and calcification of that valve. And with mitral valve stenosis, that valve leaflet starts to fuse and become stiff, and then it obviously affects the chordae tendineae, which become shortened and begin to contract. So now the valve opening narrows, preventing normal blood flow from the left atrium to the left ventricle. Okay. Again, think about the normal flow of blood, and the valve opening begins to narrow, preventing this normal blood flow. And because of this, the left atrial pressure increases, the left atrium begins to dilate, and then of course this all just backflows into the pulmonary system, so you have increased pulmonary artery pressures, and the right ventricle becomes hypertrophied. So along with these other symptoms, a patient will develop pulmonary congestion and right-sided heart failure. Okay. And then of course later on, when the left ventricle received decreased blood, preload would be decreased, and of course cardiac output falls. And as I said before, if they have mild mitral stenosis, patients are usually asymptomatic. Okay. And usually with valvular disease, to be perfectly honest with you, is the first sign that a patient may manifest with valvular disease is they just become dyspneic or short of breath. And then as that orifice starts to narrow more, that's where you see many more of these advanced manifestations. Some of the very, very late symptoms are hemoptysis, pulmonary edema, and signs of right-sided heart failure. And a lot of times, because of all these unfortunate things that begin to happen, the patient develops a lot of arrhythmias, and it's not uncommon for these patients to go into atrial fib. And I put this slide up because I wanted you to see heart failure and pulmonary edema, what this kind of looks like on a chest x-ray. And pulmonary edema is an accumulation of fluid in the air sacs or in the alveoli and the lungs, and this is where that fluid is at. So just to kind of give you a little close-up view of what that will look like. Okay. Now we're going to talk about stenosis. Or continue to talk about stenosis. It assumes that fish mouth shape caused by thickening and shortening of valve strictures. So the result is obstruction, and as I said before, increased left atrial pressure and volume, and you have hypertrophy of the pulmonary vessels. And just think about, you're having a backflow because that blood is not getting through that orifice, so you have a backflow. Remember on the first day when we talked about some of the normal functioning structures of the heart, I said the valves work on the principles of pressure and volume. Okay, so more pressure is needed to get the same amount of volume through that orifice. So that's why things kind of backlog, and that's why the pulmonary problems, along with that increased left atrial pressure and volume. Okay, And this is probably some cadaver's mitral valve, and you can see how stenotic that is. So you can see the stenosis present there on that particular valve. These are all other manifestations. You know, if you had to listen to somebody with advanced mitral valve stenosis, you're definitely going to hear a diastolic murmur. And these are all some of the very late and serious effects that can occur. Now we're going to talk about regurg, okay? And sorry about that. Let's get this picture up here, like, go back to mitral valve regurg. This is where you have, think about what that word regurg means. You don't have complete closure of that valve during systole, and with fibrosis and calcifications occurring, this is what prevents the mitral valve from closing completely during systole. So you have, with that incomplete closure, it allows the backflow of blood into the left atrium where the left ventricle contracts. Now the problem is more volume than actual pressure, and so during diastole, regurgitant output again flows from the left ventricle to the left atrium along with the normal blood flow. So now you have an increased amount of volume, which now must be ejected during the next phase or cardiac cycle during systole. So with that, you have of increased volume and pressures causing the left atrium and the left ventricle to dilate and hypertrophy. And what causes this? Usually the primary cause of mitral regurg is due to aging and ineffective endocarditis. And we're going to talk about some of those infections in just a few minutes. Other causes can be due to papillary muscle dysfunction or rupture and rheumatic heart disease. Okay, and remember, valve function depends on, that the leaflets are intact, chordae, tendineae, and papillary muscles all work effectively, okay? And those valve patencies also depend on, the left atrium, the left ventricle being structurally good and okay and normal. So if you have any abnormalities of any of these structures, that can all result in a patient developing some type of regurgitation, okay? And these are how your patients may present in an acute stage of mitral valve gurg: thready peripheral pulses and cool, clammy extremities. And with chronic, patients can have this problem for many years and not even manifest any symptoms until they develop some degree of left ventricular failure. Okay. And, again, to determine and make these diagnoses, we assess our patient's health history, look for any history of IV drug use, any history of, infections in the lining of the heart. We might do, echoes or TEEs or exercise tolerant test, may do a right-sided heart cath, to determine if there's any gradient or problems with the valves. Obviously, EKG to look at the electrical activity of the heart muscle. Sometimes we do see altered cardiac outputs with these patients because of altered stroke volume. How we manage these is, through drugs. May give patients diuretics, beta blockers, digoxin. When many of these valvular problems are due to infections, it's really important that people or our patients explain this to some of their other types of physicians that they go to, especially for their dentist, because they may need antibiotic therapy for invasive procedures like a bronchoscopy, an endoscopy, sigmoidoscopy, colonoscopies, or even for some of these patients that have dental work. And so very important that we want to prevent any further infections. Sometimes with, mitral valve regurg, because the patients have a higher risk of developing atrial fib, they may, develop a lot of clots or thrombi in that left atrium. Okay, so that's mitral valve regurg. And so with mitral valve prolapse, this occurs because the valvular leaflets enlarge and prolapse into the left atrium during systole. Usually it's a very benign condition, but it can develop into very, very pronounced and symptomatic mitral regurgitation. Most people are asymptomatic, or some of them may have some degree of maybe chest pain or palpitations, or maybe unable to tolerate exercise. Some of them may even have signs and symptoms of, dizziness, chest pain, syncope. Some may even develop murmurs, systolic click may also be heard. Okay, and again, those are can be treated, manage mitral valve prolapse with some medication. Okay, now some of these very serious valvular problems where patients are extremely asymptomatic and where it actually changes the structure and the function of other chambers of the heart. Some of them may need, surgical management for these valves. Sometimes they can have balloon valvuloplasty. Sometimes they can actually remove the calcium from the leaflets and do a direct open commissurotomy for these patients, or do a mitral valve annuloplasty involving the valve ring, or they can actually replace the valve. Now, if they use a prosthetic valve, remember these patients will need to have some type of anticoagulation, so don't forget that they have to be reminded about frequent lab values, because usually a lot of them are on Coumadin, so they'll need occasional INRs for that. Okay. All right, so let's talk about the aortic valve now. All right, and think about exactly where the aortic valve is, and it makes sense on why. It makes sense as to why the patients develop certain abnormal functions of the cardiac muscle. Okay, aortic valve stenosis. I might have said this before in class, but aortic valve stenosis is a disease of wear and tear. Think about what this valve does day in and day out, and it's responsible for opening and closing at the appropriate time during the cardiac cycle, so that blood will be ejected out to the rest of the body. So with aortic valve stenosis, where that orifice is narrowing, the effect that it has will be left ventricular hypertrophy and increase in myocardial oxygen consumption due to increased myocardial mass. And of course, over time, this is going to lead to decreased cardiac output and pulmonary hypertension. Okay? Because With aortic valve stenosis, it narrows and obstructs that left ventricular outflow during systole, okay? And so you have an increased resistance to ejection, or afterload results in ventricular hypertrophy. And as this problem becomes worse, cardiac output becomes fixed, and then you have symptoms develop where the left ventricle fails, blood backs up into the left atrium and the pulmonary system, and then of course, you know, that causes the problem of right-sided heart failure to occur. And if the surface area becomes 1 centimeter or less, surgery is urgent, okay? And these are just some kind of maybe the initial symptoms, as I said before, dyspnea, angina, syncope, but later symptoms are the following, and I won't read those to you. You can read those yourself, okay? Aortic regurg is aortic valve leaflets do not close properly during diastole, okay? And so this can result from diseases of the aortic valve leaflets, aortic root, or both. So the flow of blood from the aorta back into the left ventricle during diastole is effective, so that left ventricle will dilate, causing the ventricle to become hypertrophied, okay? Can be caused by, again, endocarditis, trauma, aortic dissection. This is a case where a person can remain asymptomatic for many years because of the compensatory mechanism of the left ventricle, but over time that ventricle begins to fail. And these are the causes, as I said before, non-rheumatic conditions such as endocarditis, again, signs and symptoms, okay? Chronic aortic regurg results from rheumatic heart disease, congenital bicuspid aortic valve, sometimes even through syphilis and chronic rheumatic heart conditions. And sometimes when we look in these people's past, we see a lot of history of IV drug abuse, causing them to develop these infections and inflammatory processes. And these are all the, diagnostics we will do. Non-surgical, again, to reinforce, using beta blockers, DIG, O2, calcium channel blockers. Be careful with nitrates because remember it works more on the venous end, so it can decrease preline too much, really then affecting eventually afterload. Watch for atrial fib, may do cardioversions or use amiodarone. Prescribe Coumadin, balance of rest and exercise, and these are some of the balloon valvuloplasty, because that's really not surgery, it's just a intervention, okay? And these are the different types of surgical management depending on the extent of the disease. So that's mitral and aortic regurg and stenosis, okay? All right, now I'm going to talk about the inflammations and infections. The first one is ineffective endocarditis. It's a microbial infection of the endocardium caused primarily by staph or strep. This one is the one that used to be called bacterial endocarditis, okay? And it can occur with patients who may have abused IV drugs, had valve replacements, systemic infections, or even structural cardiac defects. The most common organism is the Streptococcus bacteria, okay? And you might ask yourself, how does these organisms get into the system to cause these infections in these particular areas or linings of the heart? And they can enter the endocardium by the oral cavity if people have dental work, skin rashes, lesions, infections, even during surgery, during IV placements, central lines, even a regular, peripheral IV. The key to these is early detection, because once that organism gets into the system, we usually start to see symptoms within about 2 weeks. And of course, we see, the typical signs and symptoms of infection, increased temperature, but with these cardiac infections, these patients may develop murmurs, develop heart failure, petechiae. They also can develop what we call Osler's nodes, which are red raised lesions found on the hands and the feet. They can also develop arterial embolization, okay? And how we can also determine the organism, we could do blood cultures, okay? And these patients will have very, very high fevers, as high as maybe 103 to 104, okay? And these are other signs and symptoms of infective endocarditis, okay? So that diagnostic test that may be done is positive blood cultures. Patients may develop low hemoglobin, hematocrit, and definitely do an endocardiogram to determine the extent of valvular involvement or damage. Now, when they develop these infections, such as endocarditis, the mortality rate can be extremely high, okay? So it's really important, because of the seriousness of the complications that it can occur, that we get to treat this very quickly, okay? One of the most important interventions were to get them on antimicrobials, given IV for 4 to 6 weeks, particularly your penicillins or your cephalosporins. Say, for instance, if these patients have abscesses on their valves, and these antibiotics really are not working as effectively as we want them to, may have to go in there and do surgery and actually remove the valve. Again, we encourage, good aseptic technique when they go home, good hand washing, good oral care, going to see the dentist, using antibiotics during dental work, and really watching for recurrent signs and symptoms of fever, weight loss, or general malaise. These are very, very serious infections, and many times we have to get to the source, because that particular organism can still be brewing within the body, abscesses and things like that. All right. The next thing we're going to talk about is pericarditis, and all it is an inflammation or alteration of the pericardium. Can be caused by infective organisms, post-MI, post-pericardiotomy syndrome, acute exacerbations of systemic connective tissue diseases. It can also happen after somebody has cardiac surgery, okay? Assess the patient. Many times the typical manifestations include hearing a pericardial friction rub. Patients may have a little pain on inspiration, maybe have a little increase in WBCs, and a slight fever, okay? We worry about, chronic constrictive pericarditis, because remember, this involves the pericardium, the sac that is around the heart muscle, and we don't want it to, unfortunately, get too inflamed, because it could interfere with contraction of the heart muscle, okay? Really, the pain with these patients who have pericarditis is anywhere from 2 to 4. We don't really treat it with opiates such as morphine. if the pain is that intense, we need to look into it a little further. But for the most part, NSAIDs, Indocin, anti-inflammatory meds, or even possible steroids work just fine and help reduce the pain and the inflammation. Possible antibiotics, depending if it's bacterial pericarditis, possible pericardial drainage. Watch for pericardial infusion, because these patients are now at risk for cardiac tamponade. And think about your patients who may develop acute tamponade. This is a very serious and situation which is an emergency, and something needs to be done immediately. Small volumes accumulate in the pericardium and cause a sudden decrease in cardiac output, and you're going to have poor venous return. Watch for jugular vein distension, paradoxical pulses, decreased heart rate, dyspnea, fatigue, muffled heart sounds, and hypotension. This is an emergency. You may need to do a pericardial centesis. And here's a picture of what occurs where you have compression of the heart due to the fluid accumulating within the pericardium. And you can see how it does restrict contraction. Okay, so this is an emergency, and usually what they have to do is put a needle in here and remove this fluid so that you can get better venous return to the heart. That's why blood pressure drops, because decrease preload and decrease afterload. All right, so the next problem that we see in regards to infections is rheumatic carditis. Okay, and sorry, I slid a little bit too fast. All right, this is develops after an upper respiratory tract infection, again caused by group A beta hemolytic strips. This is characterized by formation of Ashkoff bodies, and all layers pretty much have the infection, impaired contractile function. You have a lot of thickening of the pericardium, and also valvular damage can be involved. Okay. Some of the serious complications, patients can develop splenic infarctions, flank pain, mesenteric emboli, and what these patients may develop with that is severe diffuse abdominal pain after eating, neural changes, and very serious pulmonary problems, pleuritic problems. Some of the manifestations which make sense: tachycardia, cardiomyogaly, new murmur, pericardial friction rub, heart failure. Again, diagnosing it through a blood culture, doing an echo, getting them on antimicrobials right away. Anticoagulants at this point are no value. Might have to do surgery to remove the structure that might have the infection or abscess or whatever. So a very serious situation. When these antibiotics are ordered, it's really important that the patient take the entire prescription. Okay. And then lastly, just to talk a little bit about cardiac myopathies. These are can be subacute or chronic diseases of the cardiac muscle. And what we really see with these is just an enlarged heart, which really doesn't pump effectively, the first one is a dilated cardiac myopathy, hypertrophy or hypertrophic cardiac myopathy. The restrictive cardiomyopathy is the rarest, and then a arrhythmogenic right ventricular cardiomyopathy. I'm not going to ask you anything regarding these on the test. I just want you to know that there are different types of cardiomyopathy, and you might see this on a physician's progress notes, or maybe as a final reading of an echocardiogram or something like that. But just want you to know that these diseases of the heart muscle exist, and that we can classify them into 4 different categories. Okay. And again, when we talk about these cardiomyopathies, when we talk about dilated cardiomyopathies, all that refers to is that both ventricles are dilated. The left ventricle is worse, and so of course you have systolic function being impaired. Okay, and with your hypertrophic cardiomyopathies, you have ventricular hypertrophy, which leads to a very stiff left ventricle, resulting in poor diastolic filling. And as I said before, with restrictive, it is the rarest type of cardiomyopathies. You have a stiff ventricle that restricts filling during diastole. And then the last one is arrhythmogenic right ventricular cardiomyopathy, where you actually replace normal tissue with fibrous and fatty tissue. And that's kind of just said very generally about what each of them entails. Okay, and this is just a comparison of chest x-rays on somebody who has a normal cardiac silhouette as to somebody that has developed cardiomegaly. Okay, these are some of the non-surgical management of patients with cardiomegaly: diuretics, vasodilating agents, cardioglycosides, ICDs, beta blockers, and calcium channel blockers. All right, and then the surgical management, obviously, depends on the type of cardiomyopathy. These are some of the surgeries: percutaneous alcohol septal ablation. They do that quite a bit. And of course, lastly, a heart transplant. All right. So that concludes a little information about valves and infections and inflammatory diseases of the heart. Okay, now we're going to look at just general peripheral vascular disease, looking at the manifestations of how a patient presents with either arterial versus venous disorders, and again talking about the medical management of these problems with medications again, and then talking about the importance of the anticoagulant management of a person or a client or a patient with peripheral vascular diseases. Okay. And think about, when we talk about arterial disease, all the different arteries and the big arteries that are in the body: the aorta, iliac artery, femoral, popliteal, tibial, and perineal artery. Okay. The lower extremity arterial disease, this just kind of points out all those really big arteries, looking at the aorta, and then looking at the femorals and popliteal, and all those necessary arteries that really do help keep the legs and lower extremities healthy. Because what we see with peripheral vascular diseases is definitely a change in the natural flow of blood through the arteries, and then of course when we're talking about venous problems, a change of blood flow through the veins. And some of these patients who develop arterial disease can have either, partial or total blockages, and think about what's occurring where now we're depriving the lower extremities of oxygen and nutrients, okay? And again, the same process of atherosclerosis is occurring in these arteries as it does in the coronaries. You have unstable and stable plaque. You can have abrupt rupture. You know, again, the same, you know, risk factors can occur just as they do with coronary atherosclerosis. 81 million people in the United States have one or more types of cardiovascular disease, and we see this very common in patients that have coronary disease. You know, also have peripheral vascular disease, and this is definitely that thickening, hardening, atherosclerosis of the arterial walls, and sometimes it's just associated with aging, okay? We'll talk about, you know, how these patients, you know, manifest with this, okay? And this is just a person who has been diagnosed with classic symptoms of peripheral arterial disease. They have what we call intermittent claudication, where that is pretty much defined as ischemic muscle ache or pain that is precipitated by a constant level of exercise, can resolve within 10 minutes or less with rest, and it's reproducible, okay? Which means, you know, it's doing the same exercise or walking the same distance before that pain returns. And as it progresses, the distance they can walk gets shorter and shorter, where they feel that, you know, that ischemic pain sooner. You know, they might be able to walk 20 feet before, but now after 10 feet of walking, they're beginning to get that, unfortunately, that ischemic pain, okay? This is just how we see those lower extremities look with someone who has severe, you know, arterial disease, thin, shiny, and taut skin. They lose a lot of hair on the lower legs, diminished or absent pedal, popliteal, or femoral pulses. When they raise their legs, say for instance they like their legs elevated on a stool or something, that foot will become very white and pale. They develop pallor with their feet when their legs are elevated, and they have reactive hyperemia of the foot with dependent position. And again, pain at rest can happen, occurs in the forefoot or toes, can be aggravated by having that extremity elevated. This is occurring because of insufficient blood flow and can occur more often at nighttime. And this is a really good chart because you kind of want to look at the difference in regards to when patients develop ulcers in the arteries compared to the veins, what kind of symptoms you're going to be seeing. I'm not going to read these, but these are very, very important to, you know, look at and understand of why they happen and think about it. We're talking about arterial side versus venous side, okay? And this is another chart that gives you that comparison of what that leg is going to look like. Think of somebody who has arterial disease and maybe somebody who develops, you know, varicosities, okay? A lot of complications from patients who have arterial disease are, you know, atrophy of the skin, delayed healing, wound infection, tissue necrosis, and arterial ulcers. And that all makes sense, okay? You know, that particular area, lack of blood supply, nutrients, and oxygen. So, of course, you're going to have tissue necrosis. Your book gives you some pictures of patients who definitely have, you know, severe and progressive arterial disease. And these are the complications, and it makes sense. Over time, when an extremity is not getting enough blood supply, these ulcers will definitely never heal. They become gangrenous, and they can, amount to infections, and as a result, amputations are necessary. And obviously, diagnostic studies are done to kind of evaluate the severity of the limited blood flow to these extremities. They do Doppler studies, ankle brachial index. When you talk about the pressures of the thigh, the calf, and the ankle, normally in the thigh and the calf they're much higher than the upper extremities. So they'll compare the ankle with the brachial blood pressures, and anything below 0.9 indicates arterial disease. They might also do, exercise tolerance testing. They do plethysmographies and look at arterial flow in the extremities, and what they see is very decreased or diminished waveforms. So those are just ways of diagnosing exactly how limited that blood flow is to those extremities, okay? And we've talked about these over and over again. Smoking, using nicotine. If these patients are at risk for peripheral vascular disease, aggressive treatment of their high cholesterols, getting their blood pressures down, and if they're diabetics, getting that hemoglobin A1C below 7. Initially, the treatment for patients that have vascular disease, antiplatelets, aspirin, Plavix are two of the common ones. First, they want to determine if, the problems are either arterial or venous. Once they do that, obviously they can, prescribe and determine, what kind of pharmacological management. And then, of course, definitely, depending on if it's arterial or venous, whether or not we teach our patients to elevate their extremity or not to elevate. And then, of course, an example of an ACE inhibitor, ramipril or altase, it's just talks about, the actions of this medication. Decreases cardiovascular morbidity, decreases mortality, hopes to increase peripheral blood flow, increases the ABI, and allows the patient to walk farther distances. Okay. And this is another one, a drug prescribed for treatment of intermittent claudication, Trental. It helps to decrease blood flow viscosity, increases erythrocyte. Erythrocyte is a fancy name for a red blood cell flexibility. So flexible means it can better move through the arterial system. And then, of course, Pledol increases vasodilatation, and again, also helps increase walking distance. Okay, so these are some of the common drugs used for treatment of intermittent claudication. And of course, encourage exercise because it improves oxygen extraction in the legs and skeletal metabolism, and walking is the most effective exercise for individuals with claudication. We encourage at least 30 to 60 minutes a day. And again, controlling blood pressure and really encouraging these patients not to smoke, because we know that smoking causes vasoconstriction. And this is just depending on their cholesterols, triglycerides, keeping their weight down, decreasing intake of saturated fat. And just other radiologic procedures to determine severity, of some of these problems that your patients have with arterial blood flow. And these are some of the possible radiologic procedures they may do. Involves the insertion of a catheter through the femoral artery. Kind of helps break up some of that atherosclerosis. Stents can be put in, especially if the vascular disease in the aorta. They can do atherectomies. Sorry, I went too fast with the slide. So, and sometimes these patients, the disease is just so severe that sometimes they need peripheral artery bypass, putting some type of autogenous vein or synthetic graft to bypass blood around the lesion. Very similar to what we do for the grafts around the coronaries. They can do these in the big arteries in the legs. Fem-pop grafts, we used to take care of these a lot in ICU overnight just to watch blood flow and assess pulses hourly. And you can see right here on the picture on the left, patient has disease right here, so they're putting a graft to bypass that disease and hopefully provide better blood flow to more distal area in the leg. And you can see this person has an incredible area of disease in the arteries, and you can see how big this bypass graft is, to definitely ensure that the extremity, especially the feet, get a better blood flow to that. They can also do, endarterectomies, patch graft angioplasties, and sometimes that's not even going to help the situation, but it's necessary to do amputations. Okay. I'm going to just kind of touch on some of these other arterial problems that we may see. Buerger's disease. Another name for that is, thromboanginitis obliterans. Relatively uncommon occlusive disease limited to the medium and small arteries and veins. Very frequently in patients who are big tobacco smokers. The veins are probably least commonly involved, and it can be even an autoimmune type disease or hereditary. It can extend into the tissues around the vessels, resulting in fibrosis and scarring. We look at the symptoms, P's of ischemia, meaning pain, pallor, pulselessness, paresthesia. Those are the things we look for in our patients with, any type of arterial disease. And as I advance this slide, you can see the end results of someone who has Buerger's disease. You can see that the tips of the fingers and the tips of the toes already have necrosis. It can block blood flow in the hands and the feet, and then the blood vessels can become inflamed. You can see how red the tips of these fingers are, and you can even see blood clots occurring. Okay, and you can imagine how painful this is, because this is ischemic pain, and the extremities are cold to touch. Sometimes, obviously, pulses are going to be much decreased, if not absent. So Oh, sorry about the dog barking. Moving on, talking somewhat about Raynaud's disease, intermittent arterial vaso-occlusion, usually of the fingertips or toes. It can be associated with other underlying diseases, and really what's happening is here you have sometimes spasms or constriction of the arterioles, causing the extremities to look like this particular picture. You can see how white her fingers are. This can happen also like in the toes. Sometimes it can come about because of stress or even changes in temperature by extreme cold. Can occur most frequently in young women. Sometimes calcium channel blockers work very well with these patients if they have this reoccurring frequently. Okay. And I just want to mention too, the book talked a little bit about subclavian steel, results from a subclavian artery occlusion or stenosis. Maybe you'll see some ischemia in the arm, and what that arm kind of feels like is very tired. Might be a little bit of a difference between blood pressure in the arm that's affected compared to the other arm. Could be as much as 20 millimeters of mercury difference. You can also see a bruit in the affected side. So all it is just basically a compression of the subclavian artery at the thoracic outlet by either a rub muscle or there's some damage to the arterial wall. Okay, so now we're going to talk somewhat about venous thromboembolism, a little bit about venous disease. Okay, so remember, these are the part of the circulation that return blood flow from the extremities back up to the heart. Remember, superficial and deep veins have valves that prevent backflow. It's kind of the action of the skeletal muscles. When we talk about venous thromboembolism, it has to do with a thrombus, a blood clot, thrombophlebitis, DVTs, pulmonary embolism, or Virchow's triad, or phlebitis. Just to review your memory, there's three parts to this Virchow's triad, and it involves stasis of blood flow, or status of blood flow, endothelial injury, and hypercoagulability. All right. These are just signs and symptoms of something that you may see when your patients develop a DVT in their lower extremity: calf or groin tenderness, Homan sign, but sometimes you can get false positives with that, so that's not a precise diagnosis of a DVT. MRIs, D-dimers might be abnormal. Those have to do with fibrin degradation products. They're present in the blood from fibrinolysis. Okay, they may do a venous duplex, an ultrasonography, or impedance plethes sonography to determine, if the patient has a DVT. Obviously, the best thing to prevent one from happening, a lot of times when it has been diagnosed, we use unfractionated heparin therapy or low molecular weight heparin. I put our patients on warfarin or thrombolytic therapy. Sometimes surgery is necessary to actually remove the thrombus or an embolectomy. Okay.